So I'm curious, as the president of this meeting, is there a session that really you found compelling that you can share with us?
Well, one that stuck in my mind yesterday, because of its uniqueness and because it was done by a small group in Ireland, and they had the idea, they did the preclinical science, and now they're taking it into patients. And if what they've done is correct, and of course they admit it needs to be validated, it's going to be very exciting. And what they did was they took blood from women and were able to show which women had a breast cancer and which women did not. Women that had, say, an abnormal mammogram. Thus raising the possibility that they could have a test for early diagnosis of breast cancer, or a test that would help us in a woman who has an abnormal mammogram deciding whether it's cancer or not. It has a lot more work that needs to be done, but if that is true, it's going to be a very exciting and major contribution.
How many women were in the study?
I can't remember the exact numbers. It was relatively small, but it was a pilot study that they were doing. And the sensitivity and specificity, that is, how often is the test giving you the right answer, and the sensitivity is how often does it miss the cancer, were really very good, up in the 90% range. And now the next step, of course, is to validate it.
You know, what strikes me too is when you say Ireland, and it really goes to the point, one, that this is such an important global meeting, and that the unity of researchers worldwide is significant.
It really is. Over about 50% of the attendees here are outside North America. And it's a reflection, I think, of the binding together of researchers from all over the world that's happened over the past 2-3 decades. I was reflecting on that because I have to introduce Martine Picard today, whose title of her talk is going to be International and so forth. And when I first got into this game in the late 70s, countries, regions of the world were suspicious of the other, so that Americans would not as readily accept results of research that came from Europe, say, and Europeans were less likely to accept research done in the United States. Partly because we weren't interacting and we just didn't know what the quality of it was and who was doing it and so forth. And then over the years, I think a lot of it due to this and other meetings that were international meetings and brought people together, gradually over the years, we became almost like one unit. We're tied together by the breast cancer issue and the breast cancer problem. And now, often studies are international studies, so they can get finished more quickly. And we're all working together as one team now. And I think I'd like to say that some of the credit can come to this meeting, but there are other meetings as well that drew people from all over the world.
So, out of curiosity, a study is really promising, and as I said before, compelling is the one you just discussed out of Ireland. What is the next step in expanding the research base from a small study base there involving more women in more countries?
Well, it's a good question, and I actually talked to the presenter yesterday about that, and they've engaged now 3 other centers in Ireland in different cities. This was originated in Galway, and so they've now engaged hospitals in Ireland, and I actually asked her if our center could participate. It would, first of all, it would give information on non-Irish women, although there's not a big reason to believe that this would not be true for other Caucasian or Anglos or even other ethnic or racial groups, but it would do that. It would help her get the studies finished more quickly. So they've been able now to get a group of institutions together and drawing up several protocols to validate the study.
Dr. Osborne, when I hear you speak about this, to me it really highlights aspects of personalized medicine. And my concern as we talk to patients, I don't want to see it become a buzzword. I feel that the description you just gave us is a wonderful example of what personalized medicine means. And because if you can begin at the earliest stage to look at what your real risk is based on your own blood sample, is this not just another aspect for you of personalized medicine?
Sure, it is. It's personalized medicine really takes into account the characteristics of the cancer and the characteristics or genetic makeup of the patient. This is sort of personalized medicine in that we can take an individual person's blood and hopefully determine whether they have breast cancer or not at an early stage. When we're talking to patients, I don't use so much the term personalized medicine during a patient encounter. I use it to describe what it is, the process and the overall paradigm. But when I'm talking to patients, I emphasize that when we're going to be talking about your treatment, this is going to be a treatment that applies to you, and we're going to look at your characteristics and then make up the best decision for you. And when you go talk to Mrs. Jones or Mrs. Smith about their cancer, they may have received different therapies, but don't feel badly about that or don't get concerned, because now each person is different, each tumor is different, and each one is going to have a slightly different therapy based on their tumor and their characteristics. So but it's definitely different. I mean, when I first started seeing patients in the early 70s in medical school, everybody got the same thing, which was very little. They got a radical mastectomy and sometimes radiation, and that was it. And then we started to introduce chemotherapy, and then everybody would get chemotherapy. And then we got tamoxifen, and everybody got tamoxifen. We learned shortly, though, that it was only the ER-positive patients that benefited. But still, it was a sort of treating everybody the same, and we don't do that anymore.
Just one quick statement from you on the mammography controversy.
Well, obviously, a task force or working group was put together to study this issue. And so over a year or more, I guess, they reviewed the literature. These were a group of people who were not experts in breast cancer at all. They were pediatricians, family practitioners, medical economists. I think that was by intent, so they could look at the data without any conflict, so to speak. And they came up with a set of recommendations that not too many people in the breast cancer world agree with. And I don't agree with them either. I think that, first of all, in the United States, we are lagging behind many countries in the rest of the world in terms of our mammography screening efforts. Sure, there are cities, areas in the country where you can point to maybe 90% of the women who should be getting mammograms getting the mammogram. But in many areas, and overall, our country really is deficient in terms of mammography. And I'm concerned that even if every other year mammography was okay for women above age 50, but it de-emphasizes mammograms. And I'm concerned that women won't even get them every other year. They'll forget about them, or
And we've worked so hard.
and we've worked so hard to bring them in, and we're not doing a very good job now. There's areas in Houston or San Antonio or Chicago where the screening rates are less than 20% in inner city women. So I think it would be a mistake to adopt these guidelines. I think that there are patients whom we can identify who do have a lower risk of breast cancer, and I do sometimes recommend every other year mammography for some of those women who I know, because of ethnic or racial factors or family history or the whole bit, could probably get away with every other year mammograms. I also disagree with the under 50. I think that women under 50, if anything, should have more frequent mammograms because they have more rapidly growing tumors, and the chance of having a so-called interval cancer in between one mammogram and then the next mammogram is much greater.
So when you say under 50, we're talking about 40, because younger than that, density is...
I think younger than that is not so much the breast density, which is an issue, but the incidence of breast cancer, of course, is very low in women who are young, unless they have a risk profile. So the payoff is very small in that group. The other thing that bothers me to some extent is we're only looking at survival. And we're looking at survival just from having a mammogram in the 1970s and a study done in this country in 1960s. Okay? First of all, mammograms weren't very good. Secondly, we didn't have lumpectomy back in those days. And third, we didn't have adjuvant therapy during many of those trials. So now we know that we can influence outcome by systemic therapy. And if we did the study today, catching a small tumor is much more likely to be cured by systemic therapy in addition to the surgery. And so I think if we added that into the equation, the mortality reductions would be even greater. Because catching a 2-centimeter tumor without any adjuvant therapy, the recurrence rate is going to be 25 or 30% over 10 years. But now and that's what it was back when these studies were done in the 70s. But now when we add in the adjuvant therapy that we're doing, catching a 2-centimeter tumor is going to be a lot higher chance of being cured. And so I think it'd be really problematic to do a study today with digital mammography, with the adjuvant therapies that we have, but I suspect the results, if anything, would be better.
Thank you. You've reinforced everything we've been discussing amongst many of the physicians here, so thank you for that.